Our goal today is really to elevate the conversation and focus on addressing anti-racism and health disparities, and also ways that health systems and physicians can address healthcare. The webinar is designed for physicians, birth workers, and any of those provider types that are in the maternal health space. We'd like to focus on challenges that physicians and staff may be faced with and ways to promote health equity as it relates to individual care, addressing interpersonal and institutional barriers. The webinar will also be a platform for participants to reflect, react, and provide a roadmap on how to learn to address anti-racism in the healthcare delivery space. I'd like to start with introducing our special guest, Dr. Wanda Barfield from the CDC. Dr. Barfield, would you please introduce yourself to the audience?
Yes, thank you so much, Dr. Johnson. My name is Wanda Barfield, and I direct the Division of Reproductive Health at the Centers for Disease Control and Prevention, which is in the National Center for Chronic Disease Prevention and Health Promotion. Just to tell you a little bit about myself, I'm a neonatologist by training and spent time in various academic institutions to include Harvard, as well as working as a neonatologist for the U.S. Army, and have had a lot of experiences with systems in perinatal health. Some of you might wonder, well, why are you interested in maternal health? And it's because it's so closely linked. The work that I do as a neonatologist, and I still currently practice neonatology at one of the large birthing hospitals in Atlanta. I know that those factors weigh heavily in terms of maternal health, how they weigh on infant health, as well as beyond and broader. So in terms of the work that we're doing at CDC, our division really focuses on maternal health, infant health, women's reproductive health. And we're really looking at surveillance systems as well as the opportunity to use data to action to improve systems and to improve the health of the populations that we're serving.
Thank you, Dr. Barfield, and really impressed with your background. I'm also a proud military officer and veteran, having served our country for 27 years in the U.S. Army Medical Corps. So really excited and impressed by your background. One of the things that always interests me as both a physician leader and healthcare executive is the ability to leverage data and capture sort of those insights from the data to do some really amazing things with regards to improving health and outcomes within those that we serve. So let's level set for the audience. When we speak about system change and changing the system from the inside out, let's sort of break apart the terminology. What systems are we referring to here?
Yes, so I think when we're talking about issues around maternal health, we're trying to solve issues from the inside out. Now, we know that in the United States, maternal mortality and pregnancy-related deaths is a problem. We also know that there are large disparities, particularly between Black and white women, American Indian Alaska Native women, and white women, and we're seeing a risk of 2 to 3-fold greater nationally and even higher in certain jurisdictions. And this is a real issue that we need to address from the inside out. And in terms of thinking about these systems, we have to think about approaches in terms of understanding the root causes of these disparities. And we are uncovering more and more data and information that helps us to understand that one of the major factors is how we're treating patients, how women are being treated during their pregnancy and postpartum experiences, how they are not being listened to, how we're have a deficit in terms of respectful care and ways that we need to address this more systematically. It's not an individual issue, it's a systems issue.
Yeah, I agree with your assessment of the current state of affairs. Having practiced in Georgia for almost 25 years, prior to my current role, I've had the benefit of supporting health plans in the public sector, Medicare, Medicaid space. And in Georgia, almost 50% of all births are to moms that are on public assistance or Medicaid. And when we speak about maternal health and maternal mortality, I know we recognize that it's not just an issue for the underserved or moms that are on Medicaid, but for women of color and other underrepresented groups across the gamut that are also on commercial insurance. So when you speak to systems, how would you like to make that change happen, recognizing that this is sort of transformational, it's a journey. So how do we step back and identify the right players to make a difference relative to the system changes?
Yes, Dr. Johnson, you bring up a great point that, these issues have been raised in the area of infant mortality as well as for maternal mortality as well. And we know that despite education, despite income, despite access to care, we're seeing certain groups of women, particularly Black and brown women, who are having higher risks of pregnancy-related deaths. And the data has been demonstrated with the pregnancy information and postpartum information that CDC provides in what's called the Maternal Mortality Review Information Application, or MARIA. And from that data, we could show, and let's take Georgia as an example, we know that there are large disparities. We also know that there are some leading causes related to health that women from Georgia, particularly Black women, are suffering from, to include cardiomyopathy as an example.
Mm-hmm.
And part of our challenge is, how do we address these disparities in a way that's systematic in terms of understanding not only the medical causes, but issues that come up when patients are complaining or expressing their concerns and they're not being heard. And I think one of the biggest issues that we know and we've experienced as an example is one of our own colleagues in this work on maternal health and addressing disparities, and that's Dr. Shalon Irving. She was a well-educated person, and I know that her story is being shared by her mother, Wanda Irving. But we need to understand that despite her immense education, her passion for the work, her ability to articulate her concerns, she was being ignored. And that's an issue that we have to address at a systems level. And it involves issues not only in terms of training providers, but making sure that we're providing quality that is equitable in terms of identifying those who are at risk and making sure that their concerns are addressed immediately.
Yeah, and I think you bring up an excellent point. When I look at and the audience looks at maternal health and maternal mortality in particular, I think we understand that from the peripartum period to even up to a year postpartum, moms are at risk. And as you've identified, when you look at those drivers, like what's causing the mortality, 80% of it is avoidable with the right identification and support. Sort of during that peripartum period, there are drivers for death around infection or health or hemorrhage. And then during that postpartum period, anywhere from cardiomyopathy, stroke, or any other cardiovascular illness that's resulting in maternal demise. And so, curious to know, are there any systemic innovative approaches that you've leveraged,
Yes.
that we could use here? Maybe give an example of some work that's being done at the CDC to help our audience?
So one example, and this is a tool that's a very important resource to, one, start the conversation and to educate everyone, and that's the Hear Her campaign. And the Hear Her campaign is a communications messaging that really talks to women who've experienced a pregnancy-related complication. And this is on our website, www.cdc.gov/hearher. And it provides information, one, first of all, stories, real stories from real people who've experienced a pregnancy-related complication and the challenges that they had in terms of getting support. It also provides some warning signs, some maternal warning signs, to include certain symptoms and signs that should raise attention and should create an opportunity to get those particular women the help that they need. And it's in a variety of languages and emojis so that it's easy to read and easy to digest. We're also doing some innovative work in terms of looking at different sectors of the healthcare system. So how can we work with community health workers? How can we work with nurses? How can we work with physicians, and not just obstetricians, but there are a variety of health providers that connect with women in the postpartum period that can really make a difference. And as you've alluded to, over 50% of pregnancy-related deaths occur from 1 week to a year postpartum. And although some women may be in contact with the health system, maybe they're being seen in an emergency room, and there's not a connection to the fact that that particular person may have had a baby within a year during that time period that they're being seen. And so we can do a lot to change our differential diagnosis in terms of assessment, and also better understand some of these factors that may be contributing to pregnancy-related deaths.
No, I couldn't have agreed more. I know in my home state of Georgia, we have 159 counties in our state, and there are more than 60 counties that have no OB provider or services available. So access continues to be an issue. And when I was in the Medicaid space, what we were seeing when we outreach moms to engage them in support or care management or their providers, some moms were entering prenatal care in their second and sometimes third trimester. And so clearly there's an opportunity to sort of shift that engagement to the left, likely prenatal care and certainly peripartum. Georgia has done a lot of work around planning for healthy babies under its demonstration, and a lot of its work to extend postpartum Medicaid coverage for moms that need help to prevent future complications with pregnancies and such. So curious to see your thoughts on sort of that approach, at least in Georgia, in areas where access to care is an issue, and that becomes a deterrent as well.
Yes. So just to talk a little bit about the whole process that we've seen in terms of system change. So we've really seen a real example of data to action with the utilization of maternal mortality review committees to then inform policymakers in terms of making change. So the specific example is that of Illinois. So Illinois' Maternal Mortality Review Committee looked at their data and noted this large percentage, right? More than 50% of women who were dying due to pregnancy-related complications in the later postpartum period, from a week to a year after delivery. And they made the proposal to extend Medicaid coverage to a year postpartum. And as many of you know, as clinical providers, often at about 6 weeks, if you're on Medicaid, you're cut off after you've had your baby.
Right.
So by making this change, there's an opportunity to continue access to care. And this idea was picked up by several other states, so that now we're seeing 45 at the last count, 45 states are now extending Medicaid coverage for pregnant and postpartum women to up to a year after delivery, which is huge. But the next question is, what are going to be the systems related issues to ensure adequate postpartum care, not only for subsequent pregnancies, but even beyond? How are we going to make sure that there is adequate and important preventive health opportunities during that time, not only to improve that person's health, but also at, moving forward as the opportunity may come up for subsequent pregnancies.
No,
So
that was an excellent example. Are there other policy changes or are there other levers that we can move the needle here relative to the maternal health crisis that we're encountering in our country? Like, what other policy recommendations might we look at?
So I think it's really important for us to think about the fact that, the real challenge is that this is not easy. It's very complicated, and there's a lot of interdependent components that occur. And sometimes, in some circumstances, the stars kind of align in terms of the data that's really informing the opportunity, the public's outcry in terms of understanding how important this is, and then the policies that may come into place and, again, address these issues much more systematically. One area that you alluded to, which I think is really important, is the issue of risk-appropriate care and the availability of appropriate facilities to care for those who are at high risk at the right time, the right place, with the right team and circumstance. And as you've alluded to, we're seeing maternity deserts in certain areas, and the issue of appropriate care for more complicated deliveries is becoming an important one. This is a potential area that we need to really think about. And you might appreciate this, Dr. Johnson, being in the military. That was a regionalized system of care. When I practiced in Washington State, we had the Western Regional Medical Command, and if there was a complex pregnancy in Alaska or in Oregon or in some other part of the West, that family and that mother was transported to a location where higher levels of care could be given and delivered. We currently don't have those kinds of systems in our current area of perinatal care, and we need to think at the very least on how these systems could be created, not only for complex deliveries, but if you also think about emergency preparedness and response. We've had several weather-related disasters where patients need to be relocated. And if we haven't set up a network of communication at the very least between different facilities in terms of geographic availability, it will be much more complicated in terms of saving lives.
No, all excellent points. And I think as we look at access as a barrier, certainly something to help address the maternal health issue that we're faced with. There are lots of other innovative approaches becoming available relative to telehealth, telemedicine, sort of hybrid delivery models, as well as I know the March of Dimes is a big fan of centering pregnancy. Curious to get your thoughts on some of these other sort of wrap support services that offer sort of local support in some of these areas where access to care is an issue.
I think it's very important, and it's also important to note that, one size does not fit all. And as we think about local opportunities for innovation, really, one, getting information from the people that we're serving to understand what might be a good opportunity to address some of these, particularly the care gaps. You know, one area that we're also focusing on at CDC is perinatal quality collaboratives. And these are groups of perinatal health providers, including both maternal health related issues as well as infant health related issues, to think about ways to improve care for families. And so just to give, you know, one example, and the great thing that I think they're trying to do now is think about quality also in the context of equity. So I'll give an example in terms of thinking about, you know, the opioid crisis, and we know that that's impacted the dyad of mothers and babies as well. And one of the approaches is the use of medication-assisted treatment, right? Which will help to reduce the risk of maternal overdose, reduce the sort of potential higher risk of more extreme results of neonatal withdrawal syndrome, and identifying people who are at risk who need medication-assisted treatment is important. But again, in some instances, there have been issues of discrimination in terms of access to medication-assisted treatment, and some of it historical perception of racism and perception of pain that may be going on in terms of Black versus white mothers. And the quality improvement collaboratives are really trying to think about ways to more equitably offer that information to make sure that Black women as well as white women are getting access to medication-assisted treatment. There's also some other approaches in terms of the care of mom and baby, and making sure that there's a support in the context of care versus a more punitive approach.
Excellent. Well, so we understand the problem. We know that we need sort of like transformation, right? So not all change is transformation. Transformation is change. Not all change is transformative. Why is system change so hard? Like, what conditions need to exist in order for us to succeed in this space, like, and make it sustainable?
I mean, I think it's true for everyone. Sometimes change is just uncomfortable, right? You're used to doing things a certain way for so long. It seems like it's working. I think the other challenge too, especially when it comes to looking at some of these broader issues of, you know, systematic discrimination, you know, we're indoctrinated in a healthcare system, and I would say we all have our own biases based on maybe experiences that were less than ideal. But we have to really rethink things, and we also need to really listen to our patients. I mean, so just as an example, I mean, the maternal mortality review committees are not just clinical bodies. They include both clinical and non-clinical representation, with representation from communities and community leaders. And that could potentially be a challenge because people have a different perspective. They're trying to come maybe from a different life experience. How do we make sure that everyone is equally at the table? And part of that is how you think about a governance around the maternal mortality review committees so that there's an equal voice for all at the table. The same thing goes with quality improvement. I think we still have more work to do in that area, but how do we include families in quality improvement without being defensive, right? How do we incorporate their concerns and their experience in a way that will help us to improve what we do? You know, again, a lot of it boils down to respect.
Yeah. And I know, as I'm sure you're familiar, a lot of our local hospitals conduct what's called a needs assessment to help them understand, sort of looking back at their data and identifying opportunities to improve the healthcare experience for patients that access their physicians or their delivery uh, birthing centers. And so, curious to know, like, what do you hope for? Like, what's your hope for the medical community and lawmakers? How do we do a better job of ensuring that what happened to Dr. Shalon doesn't happen to another Black or brown mom again?
Yeah, that is so important. I think we almost have to take it personally. We really have to think about the people that we know, love, and care about. We don't want that experience for others. We don't want another event like that happened to Shalon to happen to anyone else. And I think sometimes we try to be somewhat removed, but I think we really do need to think about fundamentally how we want to be treated, how we want our loved ones to be treated, and how can we think more broadly to make sure that everyone is benefiting from the opportunity to really listen.
Yeah, really powerful. Are there any sort of alternative or other solutions that we might have available?
So I think that continuing to, again, look at data, look at local data, better understand the circumstances, but that data also needs to include lived experiences and stories of the people that we're caring for. And I
Mhm.
know it's challenging because it takes time, it takes engagement, it requires patience and humility in terms of the work that we're doing, but it is so very important. And, many people are doing it, and it's great to see the work that's been going on in terms of these efforts, but we still have a lot of important work to do.
Mhm. And another key player that we haven't discussed as we look at this system of care and healthcare being local within the maternal health space are those community-based organizations or CBOs that might play a part in helping the hospital, the physician, the patient sort of at the center of what we do to ensure a healthy birth outcome. Any role for the community-based organizations or the community, to your point earlier around healthcare being local?
Oh, yeah, very much so. I think they have, community-based organizations have a very important role to play. They can also play an important role in terms of how we're looking at data. How are we collecting data? What is the relevant data that needs to be collected? Sometimes we're looking at certain data that may not necessarily be relevant in terms of the solutions. So, and communities need to be involved early on.
Mhm, mhm. Yeah, no, really powerful. Any last words or any sort of like from a recap call to action perspective, what would be your final thoughts for our audience? What would you like if you could list out like two or three action steps? What would that be for this audience?
Well, I think in order to transform systems from the inside, we need to listen to the people we're caring for.
Mhm.
And again, it takes time. There really is an opportunity, I think, for us to transform these systems from the inside.
Yeah. And I think something else you said that resonated throughout was making sure you have the right data points, reviewing your data, and then aggregating it in a way that provides that insight you need to devise a plan, a plan of change. It's sort of like, you've got as a health system has their own data from their experience with their patients, but there are other communities and community-based resources like the CDC, the Department of Public Health, the Medicaid agency. So lots of data points, consumer data that could help you sort of round out your profile of the members you serve, in addition to actually speaking to the patients and capturing their concerns. So any more there you'd like to share around the use of data relative to enacting that system change?
Yeah, I do think there is there are lots of opportunities to utilize local data. And again, I think it provides very important context, as well as to identify data that you actually may need in order to make systems change. And having multidisciplinary teams of people with a variety of experiences does really help in terms of making those systems changes.
Awesome. Well, you're listening to Dr. Wanda Barfield from the CDC, and we've been talking about transforming systems from the inside. I am Dr. Johnson, president of the MAA, and I've enjoyed our conversation today, Dr. Barfield, on how to transform systems to help improve the state of affairs relative to maternal health in our country. Thank you for joining us today.
Thank you, Dr. Johnson.
Bye.